Hi all, today we'll be studying on urinary bladder stones. It's also called as vesical calculus. In the last class we have studied about the anatomy and urinary bladder rupture. We'll study in the following headings: pathophysiology, types, causes, composition and cystoscopic appearance of the stones, clinical features, examination, investigations and treatment. Why the person develops vesical calculus? It's mainly because of low urine volume. Constantly having a low urine volume is a major risk factor for stone formation. So low urine volume may come from dehydration, that is a loss of body fluids from hard exercise, working or living in hot place, or not drinking enough fluids, or there is an increased fluid loss from the body. So when the urine volume is low, the urine is concentrated and dark in color. The concentrated urine means there is a less fluid to keep salts dissolved. So high salts. So when there is increased excretion of the salts, that is seen in hyperuricemia, cystinuria, hypercalciuria, where there is a formation of stones. The urine stasis, that is seen in neurogenic or neuropathic bladder, also seen in bladder outlet obstruction, where there is a retention of urine after mixturation, that is post-voidal residual urine. So again that is a cause for the stone formation. About urine pH, the normal pH range is 4.5 to 8. So when there is alteration or when there is acidic urine, so there is a formation of uric acid stones, cystine stones and oxalate stones. When there is alkaline urine, there is steroid or triple phosphate stones are formed. Then about foreign bodies, they like non-absorbable suture material or migrated contraceptive device into the bladder, and these are the causes for the stone formation. The causes for the vesical stone formations are infections, hypercalciuria, hyperoxaluria, cystinuria, bedridden and paraplegic patients, gout and other hyperuricemic patients. The other causes for vesical stone formation are diverticulations of bladder, obstruction to urine flow due to benign prostatic hyperplasia, urethral stricture, bladder neck obstructions, neurogenic bladder, cystosomiasis, foreign body in the bladder. There are two types of bladder stones, so primary and secondary. Primary stones which develops in sterile urine and often originates in the kidneys. The secondary bladder stones are due to infections, outflow obstructions, impaired bladder emptying and foreign bodies. Now we will move on to the composition of the stones. Most of the bladder stones are mixed and they are oxalate calculus, that is calcium oxalate stone, uric acid stone, cystine stone and triple phosphate stones. Oxalate calculus are primary calculus. They grow slowly, of moderate size and usually a single in number, and the surface is rough. In the diagram you can make out a rough surface or speculated surface. About calcium oxalate stones, even though the calcium is white, usually calcium oxalate stones are dark brown or black due to the incorporation of the blood pigment. So about uric acid stones, usually they are smooth, round or oval, yellow to brown and commonly seen in gout patients, bladder outflow obstruction, then ileostomies. Why uric acid stones are seen in ileostomies? This is due to loss of bicarbonate in the ileostomy effluent. So that will lead to formation of acidic urine. Along with this, there is a large amount of fluid loss from the ileostomy. So this low urine volume that will decrease is the solubility of uric acid. So that will lead to crystallization and stone formation. So cystine stones occurs in cystinuria. They contains high sulfur, so they are radiopaque. The triple phosphate stones includes ammonium, magnesium and calcium phosphates. They grow rapidly, dirty white in color and choppy in consistency. They occur on a nucleus of one of the other type of calculus. More rarely it occurs on a foreign bodies. Triple phosphate stones are invariably associated with urinary tract infections by urea splitting organisms. These organisms include Proteus, Klebsiella, Pseudomonas and coagulation negative Staphylococcus. These organisms will produce urease that will act on the urea to produce ammonia, bicarbonate and carbonate ions. Two conditions must coexist for the formation of triple phosphate stones. Number one, alkaline urine, and number two, presence of ammonia in the urine. This leads some interesting points about vesicle calculus. They are freely mobile in the bladder and they gravitates to the lowest part of the bladder. In case of bladder diverticulum, the stone is wholly or partially stay inside the diverticulum. So about the clinical features, most of these patients are asymptomatic and vesicle calculus is found incidentally. Increased urinary frequency is the earliest symptom. There will be sensation of incomplete bladder emptying, pain during micturition, that is strangury, most probably due to a spiculated oxalate calculus. The pain is referred to the tip of the penis or the labia majora, rarely to the perineum or suprapubic region at the end of the micturition. It is worsened by movement of the body. In young boys, screaming and pulling at the penis with the hand at the end of the micturition. Hematuria, that is blood in the urine at the end of the micturition. It is mainly due to stone abrading the vascular trigone. Interruption of the urinary stream due to stone blocking the internal meatus and recurrent urinary tract infection or cystitis. Coming to the examination, rectal or vaginal examination to palpate the stones, that will be normal. If there is a large calculus, that can be palpable in females. So the investigations, the required investigations are urine microscopy, urine culture and sensitivity, plain X-ray of the abdomen and pelvis, ultrasonogram of abdomen and pelvis, blood urea, serum creatine, calcium, inorganic phosphate and uric acid. In urine microscopy, there may be hematuria, pus or crystals that are typical of certain calculus. Example, envelope like in case of oxalate stone, hexagonal plates in case of cystine calculi. In most patients, the stone is visible on X-ray or ultrasound. The important point is imaging of the whole urinary tract should be undertaken to exclude upper urinary tract stone. Ultrasound of the abdomen and pelvis is diagnostic. So in this diagram, you can see the cystoscopic pictures of the stones. So coming to the treatment aspect, the cause of the stone should be identified and treated. So this may include bladder outflow obstruction, incomplete bladder emptying in patients with neurogenic bladder dysfunction. So the treatment for vesicle calculus is surgical. There are three different routes to approach the vesicle calculus. The first one is transurethral, that is transurethral cystolitholopaxy. The minimal invasive percutaneous suprapubic lithopaxy, and open, that is suprapubic open cystolithotomy. Lithopaxy is breaking the stone and removal of it. In earlier days, there was a blind lithotrite that was used to crush the bladder stones. The standard management at present includes breaking the stone using optical lithotrite or electrohydraulic lithotrite or holmium laser or ultrasound probe. So in this diagram, you can see the cystoscope attached with ultrasonic probe. The procedure is done under general anesthesia or spiral anesthesia. The cystoscope is passed through the urethra and the stone is identified. The stone is fragmented by using lithotripsy. Then the bladder is flushed using irrigators with the irrigating fluid, and the broken fragments are evacuated using helix evacuator. Ultrasound lithotripsy is extremely safe but appropriate only for the small stones. Laser lithotripsy with holmium laser can deal with most of the large stones. The contraindications for transurethral lithopaxy are urethral stricture that cannot be dilated sufficiently when the patient is less than 10 years, contracted bladder, and when there is a very large stone. When it is not possible to do transurethral cystolitholopaxy, then there is an option for percutaneous suprapubic lithopaxy. In this, first to insert a wide bore needle into the bladder through the suprapubic area. Then a guide wire is passed through the needle. Then needle is removed. Alkene metal dilators are used to dilate the tract. Then laparoscopic sheath, that is amplified sheath, is inserted through the dilated tract. Then laparoscope is inserted through the sheath. Then the stone is broken and broken pieces are removed. When there is a large stone, suprapubic open cystolithotomy can be done. Here a small incision is taken over the suprapubic area. The bladder is approached extraperitoneally. The bladder is identified by the detrusor muscle pattern, which is crisscross, and it is opened at the fundus. The stone is removed and the bladder is closed using absorbable sutures. So please remember, never use non-absorbable suture material because it can act as a cause for the stone formation and recurrent urinary tract infection. Then place the suprapubic catheter and also urethral catheter. Then close the wound.